Hello, everyone. This is Mike Taylor. Welcome to the first episode of the Workplace Safety Review. I am the OSHA Practice Chair at Greenberg Traurig. I am located out of our Washington, D.C. and Northern Virginia offices. I am very honored to have Dr. John Howard as our guest speaker today. John is the director of the National Institute for Occupational Safety and Health. And he's also the administrator of the World Trade Center Health Program in the U.S. Department of Health and Human Services. Dr. Howard was first appointed NIOSH director in 2002 during the George W. Bush administration and served in that position until 2008. John, welcome. Thank you for agreeing to speak with us today. Wanted to talk with you a little bit about NIOSH and obviously the coronavirus, as that is a timely topic these days. In terms of NIOSH, can you give us the listeners a little bit of background about how NIOSH got started, what it is, its role, that kind of thing?
NIOSH is actually going on 50 years. It began in 1970 with the Occupational Safety and Health Act of 1970, in which NIOSH was specifically established, named as an agency within the Department of Health and Human Services. I always like to point out to all of my friends at OSHA that the Occupational Safety and Health Act did not actually establish OSHA as a statutory agency. All of the duties in the OSHA Act are assigned to the Secretary of Labor. But subsequent to the enactment of the Act, the Department of Labor established administratively the Occupational Safety and Health Administration. So NIOSH is not in the Department of Labor, which a lot of people think is a little odd. But the framers of the Occupational Safety and Health Act, way back in the last century, the end of the 1960s, thought that it was best to leave the research agency that did research in occupational safety and health in the Department of Health and Human Services to insulate it a bit from some of the pressures that regulatory agencies often have. Such as OSHA. So we are located in the Department of Health and Human Services. We are administratively within the Centers for Disease Control and Prevention. Our job is to generate new knowledge in the field of occupational safety and health, and then to disseminate that knowledge to practitioners, to employers, to workers, to academics, to the entire stakeholder community that is interested in occupational safety and health. And as I said, we've been doing it now, going on 50 years, and the nature of our work has changed over the decades, and that has kept us on our toes over the last 50 years. One of the things that we do as a part of CDC is that we participate in these large emergency responses that the nation goes through periodically and unfortunately. So our role in whether you're talking about 9/11, whether you're talking about Ebola as a outbreak or you're talking about coronavirus pandemic, our role is to ensure that workers who are responding to these large pandemics or epidemics or outbreaks or disasters like the Deepwater Horizon, well protected in their response work. So that chiefly involves a lot of personal protective equipment issues, respirators, for instance. NIOSH has responsibility in its National Personal Protective Technology Laboratory in Pittsburgh to test respirators. And so in the current coronavirus pandemic, we've been doing a lot of work in that area. So that's a sort of a short update, Mike, for what NIOSH is and what we do.
You bet, you bet. I noticed that NIOSH has been involved in issuing some of the guidance materials that have been generated to the public in response to COVID-19, some with OSHA and some with not, I think. Can you tell the listeners about these guidance materials? I mean, I'm interested as well. How are they developed? Is there risk assessments done? Who's involved? Who has to give the final approval on these types of things? Like, what's the ins and outs of how these guidance materials get promulgated and sent out to the public?
I'd say it's a complex process. Clearly, the guidance is needs-based. So in the early part of the pandemic, February, March, into April, the needs were, what is this thing? Who's at risk? How does a workplace respond to these issues? That's morphed a bit into the May phase, in which we see more workplaces deciding to either expand their operations or to reopen their operations. During the early days, for instance, we had the issue of essential workers, certainly in healthcare. So we had a lot of guidance that was needs-based in healthcare. And as an example of that kind of guidance is the issue of filtering facepiece respirators, which, as many of the listeners know, are in short supply, very critically in short supply, almost to a crisis proportion early in the pandemic. And so we had to look at how do we ensure that healthcare workers can remain protected, but at the same time within the reality of these crisis shortages. So we did a number of guidance that tried to assist in that area, how to optimize the use of existing N95s, looking at the issue of whether surgical face masks could be used in lower risk situations, saving the N95 for aerosolized procedures, for instance. Looking at the issue of stockpiled N95s that may have expired and how a healthcare hospital situation could use those respirators. Recently, last month, we issued guidance about how to decontaminate filtering facepiece respirators. Not something we've ever thought of doing, and certainly not something manufacturers think is a good idea. But again, the need for the use of N95s that are in short supply is necessary to consider how you go about doing that. We have a new app which we developed called the PPE burn calculator, which gives hospitals an idea of their supply and how fast they're going through various PPE, in addition to respirators and gloves and gowns and shields and other things. So another example of how these guidances are developed that NIOSH participates in. As an example, we began to see back in April an increased number of cases of COVID-19 occurring in meat and poultry processing. So we assisted state health departments and plant operators and USDA in going out to these plants and looking at how we could offer technical assistance so that their risk of the workers getting N95 in the plant would be less. And as a result of those investigations, we developed guidance document for meat and poultry. We worked with OSHA on that, so it's a combined CDC OSHA guidance on meat and poultry processing. We also are working with OSHA on developing guidance in agricultural settings, in manufacturing settings, in maritime and construction and other settings. So as we see essential or critical infrastructure operations continue, for instance, in meat and poultry processing, as you know, the president issued an executive order saying that they had to remain open. And as we see other industries starting to open, we're developing guidance for them in conjunction with our subject matter experts. So I would say the answer to your question is it's needs-based based on the evolving situation that we're in this pandemic.
Right. Hey, thank you. That was very, very helpful. You know, I get questions a lot from clients about these guidance materials. For example, you know, should we follow all of them recommendations within a certain document, or are we allowed to just do, I don't know, let's say 8 out of the 10? And the best piece I've been able to give folks is to say, this is really a tool to help you brainstorm and develop a plan that suits you and what you do for a living and where you're located. Because obviously, if you're located in New York City now, your situation may be completely different than someone employer located in Billings, Montana, for example. So, I mean, would you agree? It's kind of it's a tool that you can use to brainstorm and to help pinpoint what you think is going to work at your workplace, depending on where you're located.
Yeah, I would agree with you. I think that last part is extremely important. You know, we encourage employers, no matter where they are, to check the caseload in their area. Make contact with your local health department so that you know what's going on in your area. I think that point is extremely well taken, and thank you for mentioning that. I generally agree with you that, you know, what we're doing in issuing these recommendations is that we always stress, look, these are not regulations, okay? There's no requirements here. You're exactly right. Look at all of these recommendations. Check out the feasibility. If you can do them all, I think that's a maximal risk reduction. If you can't, and for instance, in the meat and poultry processing, which is a great example, you know, there are limitations. The physical layout of the factories, the work patterns in there, the labor intensiveness, the closeness that workers have to stand to each other, the lack of automation. This is very, very labor intensive. We go in there and we offer the recommendations to the plant operator, starting with the hierarchy of controls. You know, can you eliminate the hazard from the workplace? And here the hazard is the virus. How do you check employees coming into the workplace? Temperature checks, asking them how they feel. If they're sick, send them home. Looking at your leave policies and your sick policies. And then going to engineering controls. In the case of meat and poultry, can we separate these workers? If not, can we put partitions between them? Let's look at the ventilation rate, et cetera. And then a lot of administrative controls are always operative in any of the guidances that we issue for business, for any type of business. And so obviously, no one employer can probably do all of them, but we offer as many as we can so that the employer will do exactly what you're recommending, Mike. Look at all of them, see which ones that you can do to maximize your risk reduction. That's our intent. We're not ignorant of the fact that in certain production operations, things are pretty difficult to change, and we're extremely cognizant of that. In consumption or services like grocery stores and retail stores, it's the same issue. Can you put a partition between the customer and the clerk? Can you move your credit card reader outside of the employees zone so that they're not touching it, and they don't have to enter the credit card and all of that. So all of these things that we recommend in any of the guidance that we do, we try to put everything in it so that it gives employers a maximal list to operationalize. And clearly, if you can operationalize all of it, that's a maximal level of risk reduction. If you can't because it's not feasible, then you try to do as much as you can.
Right, right. One of the things that I noted in the interim guidance for businesses and employers responding to coronavirus, May 2020, you mentioned this earlier. It says employers should respond in a way that takes into account the level of disease transmission in their communities and draft a plan accordingly, right? My question is the community. I give an example. I believe Governor Hogan in Maryland I believe we're going to go into phase one here pretty soon, but he's giving the discretion of county executives whether they want to continue to keep a lockdown, if you will. But if you look at, let's say, Montgomery County, Maryland, I think there's roughly around, 45 zip codes, but you can see the map of where the outbreak has occurred. There's one zip code that has 0 coronavirus cases. So a restaurant, for example, in that zip code may not have to do as much as, let's say, someone in a zip code where it's high incident and fatality rate, and that we should really look by zip code when you're looking at what your community is as opposed to a county as a whole, because a county can be large in some places. Would you agree with that?
Well, certainly. Some counties, especially the counties that, as you mentioned, border the District of Columbia, like Montgomery County, or have a higher population. And I think if you're a governor of a state like Maryland, and you have a business in Western Maryland where there are a lot of farms and the density of the population is very low, that's a different situation than if you're in Prince George's County, where the number of cases are probably highest in Maryland, including the city of Baltimore, Montgomery County. You have a different graduated scale in terms of the things that you have to do. You have to remember, though, that someone can come into your restaurant in Western Maryland and be asymptomatic. So you don't want to completely think you're on another planet here. But I agree. You look at the area. You're saying zip code. I have no reason to doubt that. I always say check with your local public health department. Every county has one, and they can give you a good idea of neighborhoods. For instance, like in the district, we look at wards. So certain wards have higher incidence than other wards. I think the more information you have, and the bottom line, Mike, is the more information that an employer has about what's going on with the virus in their locality helps them.
Right. Be in a better position to respond accordingly. I know one of the questions I've gotten in the last few weeks about the face mask as opposed to N95s, which are true PPE, whereas the face masks that we're having to wear in and out of grocery stores, for example, aren't really designed to protect the worker. They're designed to protect the worker's colleague. Has there been any studies that you're aware of to determine the effectiveness of these kind of face cloth masks, and are they detrimental to someone who, let's say, has asthma or COPD if they have to wear it for a prolonged period of time?
Well, these are great questions. I'll take the latter one first. You obviously don't want a cloth face mask that's so thick that it increases the breathing resistance to anybody, whether you have asthma or not. So you don't want perhaps more than 2 layers. And most of the guidance that's on the website, including CDC's guidance about how to sew and make a mask, suggests that you don't want a super thick one because you're not going to be able to breathe through it, and you're not going to wear it for very long because it's going to be objectionable. The issue about effectiveness, we have never, CDC has never recommended that people run around with cloth facial coverings. This is brand new. And it came about, as you say, a cloth face covering protects others because of this issue of discovering 6 to 8 weeks ago that the percentage of folks that were asymptomatic, in other words, that did not have any symptoms of COVID-19, but may be shedding the virus nonetheless, is actually pretty substantial. Any studies anywhere from 5 to 25% of people tested, no symptoms, may have the virus and may be shedding it. There's a good study that was done in New York City of women coming in for delivering a baby. They had no symptoms and they were tested. 13% of them were COVID-19 positive. So the issue about a number of folks who are in the population, who are going into restaurants, going into retail stores, going into here in Washington, the metro system, getting on a bus, etc., who actually are not symptomatic but may be shedding virus, caused CDC to say, now what can we do about that situation? Well, we don't have enough respirators to even supply hospitals with as many as they want, let alone general population. So hence the solution of cloth facial coverings. As you say, it protects others. So if you happen to sneeze or cough, blow your nose or whatever, there's some protection that others around you will have. Not the same protection that a respirator has, which protects the wearer from others. So that's sort of the story, Mike, of the facial coverings. It's related to the discovery of an asymptomatic proportion of people in the population that may be shedding virus.
Thank you, John. That's very informative. And, due to the shortage of N95s and other PPE for hospital workers, I guess this is the next best thing, right?
Exactly. And, that phrase, Mike, the next best thing, is distressing to a lot of people because we wish that there were enough filtering facepiece respirators that would not be a problem, would not be a shortage in healthcare settings. But even with a very robust a restoration of the supply of filtering facepiece respirators, you can't have the American population. There will never be enough for the entire American population. Therefore, the cloth facial covering.
Right. Have you seen an uptick in companies, either in America or outside America, trying to make N95 masks and get them certified?
Oh yes, yes, definitely. We've seen the existing traditional respirator manufacturers, 3M, Moldex, MSA, all of those types of existing manufacturers are doing a super job cranking up their production lines to produce not only filtering facepiece respirators, but also elastomerics and PAPRs. We've seen that, but we've also seen new non-traditional companies enter. We've seen, and it's not only respirators, we've also seen that in terms of ventilators, face shields, and gowns and other protective equipment. So some new manufacturers have entered, and they have then been sending to us their products for approval because they're not obviously approved before. We've never seen them before. And just for the listeners to know, what we do is we test the respirator for its filtering capabilities. So we want an N95 to filter 95% of small particles. We also test for the fit, how well the elastic straps work. So those are our two main things that we do in order to approve the N95. So the answer to your question is yes. We're seeing existing manufacturers and new manufacturers try to help us fill the shortage of respirators, especially in the healthcare setting.
Terrific. Thanks, Sean. Another topic I want to talk to you about, one of my favorite topics, social distancing. Look at the word social. It's anything but social when you're trying to implement some of these concepts of distancing folks from others to prevent the spread of the virus. Is this something that's new, or is it the concept been around for a while with other viruses, that is social distancing?
Well, first of all, I use the term physical distancing because, as you say, we don't want to interrupt social interaction between people. Human beings are social animals, and we want to promote that. And there's lots of ways that we can do that virtually now. But physical distancing is not new. It's based on the principle that you want to separate as much as you can the infected individuals from the uninfected individuals. That's the principle. That's the underlying principle. And it's based on the fact the virus doesn't have wings and the virus doesn't have feet. The virus needs people to be close to each other, generating aerosols, large and small, from breathing, from speaking, from singing, from coughing, from sneezing, from an infected individual to an uninfected individual. And you got to be close enough for the virus to get from that infected individual to the uninfected. So if you can interrupt that physical closeness, then you decrease the chance that the uninfected individual around an infected individual will get the virus, establish infection, and become sick. So it's not a new principle. It's been around since the Black Death in 1347, and it's a historical principle. Unfortunately, right now, in the absence of medications or vaccine, it's the thing that underlies all of our thinking and all of our recommendations. If you look at all of the guidance that CDC has put out, you see this principle throughout, separating the infected from the uninfected.
Right. And what I've been seeing too, or questions I've gotten, is basically this: if we can't comply with NIOSH and CDC's recommendation of 6 feet physical distancing, we're just not going to do it at all. I know it's not a workplace setting, but I give an example. My daughter is a part of a summer swim league that has thousands of kids that swim outdoors for the summer, and as of today, they've decided not to have summer swim meet season because they didn't think that they could comply with this 6 feet rule, or guidance, if you will. And I think that that's misguided because as we talked about originally, if you can put all of this stuff together, some of it, whether it's PPE, some social distancing, the best you can, your cleanliness, your response programs, those kind of things, you just have to do the best you can instead of, if I can't do 6 feet, then I can't work, that type of thing. Have you been getting lots of questions about that in particular?
Well, yeah, I'm not sure exactly how to run a swim meet, but it does take a lot of thinking, a lot of energy, and it takes a lot of work to be able to do any activity that involves a large number of people and keep them separated from each other. And as an example, back to the workplace, because I don't know about swim meet issues, but in the workplace, for instance, with essential critical infrastructure workers, for instance, like in meat or poultry processing, where they've got to continue working, and yet they're working very close together, we've recommended partitions between each individual, plastic or stainless steel, to be able to separate folks on a work line. We've recommended the same thing in a lunchroom, staggering shifts so they're not there all at once, running 3 shifts, with one of those shifts actually being a disinfection shift, for instance. So, again, it takes a lot of work to do this, and that's I think the pandemic era that we're going to be in for a while, is that we've got to think through how to do this. So whether it's a swim meat or a meat or poultry processing, we're all in the same boat. We have to be creative about this. Now, in workplaces, we can't just close a meat or poultry process, and we can't just close a grocery store. So we've got to come up with ways to do this. And there are some creative ways that I've seen that workplaces have done this, and certainly the issue in our recommendations about administrative controls that one could do, including staggering shifts, not bringing everybody to work at the same time, et cetera. All of those things are possible. So I'm not familiar with the swim meet situation, but in workplaces we're having to do that.
I think that goes back to what we were talking about originally, is that, you're looking at what's the level of disease transmission in your community. And that will really dictate on how much you should implement, if you will.
Sure. I think you're exactly right. And I think as more than I, as an attorney, and the listeners who are listening here are attorneys, there are liability considerations that a lot of non-essential congregate activities probably consider.
Absolutely. One of the things that, I don't know if anyone's approached you about this, but I know there's been some calls for OSHA to promulgate a temporary standard on the virus in the workplace, and so far, I think OSHA has chosen not to do that. Has OSHA approached NIOSH about a possibility of a temporary standard?
Yeah, I think you're exactly right that a lot of folks have been interested in the federal OSHA adopting that type of standard. As you know, California adopted a aerosol transmission disease standard a while back, and that has, I think, been looked upon as perhaps a model for other states and for federal OSHA. And indeed, in the current draft of the House bill, the next tranche of money, they actually, I think, have a provision there requiring OSHA to do that. I think OSHA doesn't think right now that it's necessary, and I think you'd have to check with them on the specifics there in that area. So we're always happy to assist OSHA. As you know, we've done co-branded guidance in meat and poultry, as well as doing it at agriculture, and we're hoping to do it in other areas too. So I think that if OSHA is interested in that, we'd be happy to help them.
You think it would be difficult to do? And the reason why I ask that is because I'm not familiar with any kind of testing device that could test the surface or the atmosphere and determine that you actually have COVID-19 in the workplace, as opposed to, let's say, lead. You can sample a desk or sample the air and determine how much lead you have in the air, where the virus is this, as you said, it doesn't have any feet or arms, and it's fluid and it moves around. And it will be very, very hard to determine if it actually is indeed in the workplace, unless, for example, you're a hospital and you have a patient in front of you that has been diagnosed and has coronavirus. And in that case, you have the virus in the workplace.
Well, I think you raise a really interesting and incisive point. This issue about, how you test for the virus is an experimental one, and it's one of research interest to NIOSH, and it's also of research interest to the Department of Homeland Security to a part of Homeland Security, which is called the National Biodefense Analysis and Countermeasures Center, the NBACC for short. And you may recall a couple weeks ago when a gentleman came from DHS and did a briefing at the White House podium, and he talked about the testing for the virus in aerosols. He also talked about whether sunlight and various disinfectants will kill the virus. That was sort of a notable event because the president started asking questions about that issue that became a news story. But if you look at the issue of the sources of aerosols, infectious droplets, how to test for them, this is something that NIOSH has been working in a work group with the NBACC, with EPA, and others, trying to figure out how we really do this. And and again, this is research, so this is very, very early research. The NBACC is looking at a number of samplers, that could be used in a place or in a hospital, no matter what, to be able to say, well, is there virus present? Now, a lot of studies on environmental persistence on surfaces the way they decide that the virus is there is through testing for RNA. In other words, pieces of the virus may be there. But those studies are somewhat limited because they're not testing for the live virus, for the viable virus. And that's hard to do because you need a good sampler, and then you need a laboratory that can handle the culturing of live virus. Obviously, culturing SARS coronavirus 2 is a very risky proposition. So the NBACC has a plan to start work in this area. One of the samplers that they're considering using is a NIOSH-developed sampler that we used for influenza, for instance. And we're hoping that our sampler might be one that they could use. But there's several other samplers that they're going to be using. So that thread of research, like you referred to, Mike, is sort of just starting. And I would imagine that in a month or two or three, we will have probably procedures, method, and a sampler where we could go into a workplace and see if there's live virus on the surfaces or in the air, in aerosols or on the surface. So I really appreciate your question because it allowed me to tell you about this exciting area that we may see mature in the next couple months.
That is terrific. That is great news because, if that can come to fruition, that will really be able to help employers protect the American workers.
Exactly. Yeah. And it's the paradigm that we're all used to, Mike. We're all used to industrial hygienists coming in and saying, well, you got, asbestos fibers there, or you've got benzene there, or whatever. That's part of our occupational safety and health paradigm. So we're very excited about the possibilities here. Viral testing, which we pioneered during H1N1 back in 2009, we showed that in hospital waiting rooms, emergency rooms, etc., we could find influenza virus with our sampler. So that goes to the issue of how you judge whether your disinfection is working if you can sample. So it's a little risky because this virus can cause severe disease. So we have to be very careful how we do this. So I appreciate again you asking that question.
Well, we look forward to hearing more about the research down the road. As we're closing out, John, if you have the ability to be in the boardroom for the lack of a better word, for employers across America, what three things or three takeaways would you tell them that they should consider in dealing with this as we reopen the economy?
Well, I think the message that we've tried to impart in all of the guidance is let's look at this from a hierarchy of controls perspective, because that's what we're used to in safety and health. And let's make a list, as you said early in the podcast here, let's make a list of what you can do. Select from this menu of options what you can do that is feasible within your workplace, given your workflow and production operational constraints, etc. What can you do in the hierarchy of controls for hazard elimination, for engineering controls, and the large number of administrative controls that can be done? And then lastly, the issue of PPE, but of course, we have to substitute that, unless you're in a healthcare setting, we have to substitute that with facial cloth covering. Is that appropriate for you to do for your workers, to require that for your workers? So my message, I guess, would be, let's start out with the hierarchy of controls, and let's go through each one, and let's do an analysis of what we can do operationally.
Terrific, John, terrific. Hey, thank you so much for agreeing to be on the Workplace Safety Review podcast today. I would have loved to have seen you in person. I haven't seen you in a while. Your knowledge is always very helpful to the regulatory community. We really appreciate your service and all the hard work that you do to try to ensure that the American worker is safe going back to work whenever we're going to reopen the economy.
Well, I appreciate it, Mike. Let me know if I can be of any other assistance.
You bet, you bet. Listeners, stay tuned to the next episode of the Workplace Safety Review. Signing off, Mike Taylor.